Hello, this is Dr. Drew Howard, and I'd like to welcome you to our webinar. Thank you for checking our website out, and hopefully we can give you some great information today on bariatric and weight loss surgery. And I look forward to hopefully seeing you soon in the office to continue our conversation and answer any more questions you have. A little bit about me first. Some people like to know I'm board certified by the American Board of Surgery. I did my bariatric fellowship at the University of Florida in Gainesville, Florida, specifically focusing on bariatric surgery and all weight loss surgery. Did my general surgery residency in Alabama, my medical school in San Antonio, and before that, proud graduate of Texas A&M University. Today we're going to talk about the problem of obesity, some of the surgical treatments specifically for obesity, and what kind of outcomes you can expect from those various treatments, the good and the bad. And then next steps. There are a number of steps that you have to take to get from this point to surgery, and we have an office staff that does this every day. And so we can help you get there without a problem. Just as soon as you come into the office, you'll meet our bariatric coordinator, and we can get you on the road to success. First, we have to define obesity. Obesity is defined by what we call BMI, or body mass index. What this is a height versus weight ratio. Because obviously if somebody is 6 foot and a half feet tall, and they weigh 250 pounds, their BMI is not going to be as big as somebody who's 5 feet tall and weighs 250 pounds. So what you can see is if you are 19 to 25 BMI, you are what we call normal weight. 26 to 30 is what we call overweight. 30 to 40 is what we call obese. Over 40 is considered morbid obesity, and super morbid obesity is greater than 50. What you can see here is a graph that kind of points out weight versus height and gives you kind of the BMI. What you can see is everything in this reddish orange color are people who qualify for surgery under their insurance based on their weight and usual medical problems. We do surgery on people with BMI lower than this, but unfortunately most medical insurance companies will not cover it. We notice there's a huge obesity trend in the United States. What you can see looking back over the past many decades is in the 80s and 90s, only about 10% of people had a BMI over 30. What you see is when we turn to 2000, now you're getting up to around 20% of people have a BMI over 30. In 2010, we saw that now that's over 30% of people have a BMI over 30, putting them in an obese or morbidly obese category. That comes out to well over 130 million U.S. adults are considered obese. And the problem is with obesity is it causes all these other medical problems that you can see this lady on the right part of your screen has. Whether it's liver disease or gallbladder disease, high blood pressure, reflux issues, heart problems, sleep apnea, type 2 diabetes, fertility problems, arthritis, all majorly affected by her obesity. In fact, obesity has become the second most preventable cause of death in the United States, second only to smoking. Now, BMI versus mortality, what you see on these graphs is once your BMI starts to get up over 35, your mortality risk, meaning your chances of dying in a single year, get up over twice that of somebody who is normal weight. So what are the causes of obesity? Well, it's kind of a three-headed monster. First is the obvious one, the environment we live in. What you can see is when Burger King and McDonald's first came out with burgers and French fries in the 1950s, they were this size. But now we can supersize anything we want. And we call those original burgers and French fries Happy Meals. You see Coca-Cola, when they first came out 100 years ago with Cokes, that they were 6.5 fluid ounces. Now you can't even get that size anymore, but you can get a Route 44 if you would like, filled with sugar and a whole lot of calories. We do know there is a genetic component. Obviously, obesity runs in families. We know that the adult BMI of an adoptive child is actually closer to his genetic parents than it is his adopted parents. So it doesn't matter his environment as much. His genetic component makes a huge difference. One of the genetic and hormone factors that we see is ghrelin. So ghrelin is a hormone. It's made in the fundus of the stomach, which is when I show you a slide of the stomach, it's the upper right portion of the stomach. And what it does is it tells you you're hungry and stimulates appetite. On this graph, what you can see is ghrelin peaks 4 times a day: breakfast, lunch, dinner, and midnight. Compare that to somebody down at the bottom who's had a gastric bypass or a gastric sleeve. This area of the stomach is no longer in function because it's either been bypassed or removed, and people don't have these hunger swings. These are the things that make dieting very hard because you're constantly hungry. You don't have that problem after surgery if you have a gastric bypass or a sleeve gastrectomy. All bariatric patients have worked hard at losing weight all their lives. If you're listening to this, you're no different. You probably tried 1, 2, 3, or even 5 or more of these diets. The problem is we know dieting doesn't work. The NIH did a study way back in the 90s that showed if your BMI was over 35, your chances of getting the weight off and keeping it off for more than a year and keeping that BMI below 35 was 3% or less. So the fact that you feel like you've been a yo-yo with your weight and you can't keep the weight off doesn't mean you're abnormal. It actually means you're normal. The NIH, based on this and a bunch of other studies, said in 1991 that surgical intervention is the only method proven to have significant long-term impact on the disease of morbid obesity. And they caveated that with when medical interventions have failed, which is why many times you have to have a medical evaluation period. We will help you get through that with your primary care doctor or in our office once you come in. The best medical weight loss is actually surgery plus proper dieting, behavior modification, exercise, and proper psychological counseling to affect to the new you after surgery. So what are the surgical treatments of obesity? Well, there are 4 FDA-approved surgeries being done in the United States right now. I'm going to focus on the first 3 and not talk too much about the duodenal switch. I can do a duodenal switch, and if it's something you'd like to talk about, I'd be glad to talk about it more in the office. It's only done about 1 to 2% at most in the United States, and comes with a lot more complications, but I would be glad to talk with anybody who's interested in that operation. The gastric bypass, the gastric band rather, is a device that is put around the top part of your stomach. And what that allows to do, food comes in, just hits that band, distends the top part of your stomach, and then gets digested a little bit to where it can then go through the band to the rest of your body. When that area above your stomach, above your band gets distended, that stomach sends signals back to your brain saying you're full. This works by pure restriction. You can only eat so much. If you overeat, you will throw up. If you throw up a lot, it can be rather miserable and you can actually dilate the top part of your esophagus. Some people like to say this is a reversible operation. I like to say it's a removable operation because it leaves a lot of scar tissue behind when we remove the band. It is a low operative risk and it is an outpatient surgery. You come in, we do this surgery, you go home just a couple hours after we're done. This weight loss for this surgery is rather slow. We expect you to lose just a couple pounds a week over a 2 to 3 year period. You can cheat on this, especially with liquids. that have a lot of calories in it, so you have to be very careful. And you need to come back to the clinic for multiple visits and adjustments. See, the band is attached through some tubing to a port that sits underneath your skin. I have to take a needle in my office and stick that into that port multiple times and give you fills, which is some fluid to make the band a little tighter. Uh, if you're scared of needles, this is not a good operation for you because we'll have to have multiple fills in the first many years of having a band. Some people don't like this because it's a foreign object. And of all these operations that I will talk about, I do them all laparoscopically. It's all through very, very small 5 millimeter incisions, but I have to make 2 incisions bigger to get the band in and the port in on this. So I actually end up with the biggest incisions with a band compared to the other 2 operations. A big concern of a band is a slip. We know that about 15% of bands will slip in the first 5 years, and the problem with a slip is it can lead to an erosion. Erosion is bad because you can actually have the band actually erode through part of your stomach, and that can cause some serious adverse events in your life. We know up to 1 in 4 people will get pouch and esophageal dilation, which everything above the band gets just dilated and bigger, which leads to increased reflux. These are some reasons that we take out a lot of bands recently. Because of these couple of reasons above. Then there's the sleeve gastrectomy. This by far is the most popular operation we do in the United States right now. And we do many of these a week. What this operation is we create a very small stomach by removing about 75 to 80% of your stomach. Your stomach, as you can see on the screen, will look basically like a banana when I am done. This is a restrictive operation as well, but changes many hormones to help with all the other medical problems. As we talked about already, it removes ghrelin, so it removes that desire and that hunger factor. This obviously is not reversible because the part of your stomach that I remove, I cannot put back in. The average weight loss for this is significantly more than the band. You can expect 65 to 75% of your excess body weight to be lost over 18 months. It only requires 1 night stay in the hospital and 2 days total in the hospital. The advantages of this is there's no foreign object like the band. Is also there's no dumping syndrome, which is a problem that you can have with the bypass down the road. There's no need for those fills or the adjustments like the band, and is a simpler and safer operation than the gastric bypass. In fact, it's even safer and having less complications than the band itself. I believe this is the safest operation for anybody who's a BMI greater than 60. And will give you great results. And if you need further operation, we can then switch you to a gastric bypass or a duodenal switch down the road. It by far, once again, has the least amount of complications compared to any of the other bariatric operations currently. The big complication we worry about is a leak. This happens about 1 to 2% of the time in the United States. And this is where one of those staples don't form well or get busted open. The way we prevent leaks is 1, I use a reinforcement device on top of the staples to hold them into place even better. I check with a scope going down your mouth and into your stomach, looking on the inside and blowing it up with air while I put water into your belly through my laparoscope. That allows me to do just an air test, much like an air tire test on a bicycle. By dunking your stomach under the water, I know you are airtight before I ever leave the OR. If you're not, I will fix it until you are. Stenosis or stricture can happen about 1% of the time after this operation, but it's obviously very rare. And then some malabsorption of vitamins we have to be concerned about. This is why after surgery we will require you to take some bariatric vitamins, which we can provide for you in the office. You'll just take 3 of these a day, and that's all you will need as for a multivitamin or any vitamins. Gastric reflux has been reported after this operation. It's been my experience. If you do get a little extra gastric reflux after this operation, it will go away within 4 to 6 months. For those who have gastric reflux before this operation, many times it is due to a hiatal hernia, which I can fix at the exact same time as I do this operation, and your gastric reflux usually goes away right away. Then there's the gastric bypass. The gastric bypass is the tried and true surgery. It has been the gold standard for years. We have been doing this operation since the 1960s, and while other operations have come and gone as weight loss surgeries, the gastric bypass has stood the test of time. The way the gastric bypass works is we create a small pouch that is just a little bit bigger than the size of a large egg. We then take your bowel that was usually connected further down, and we connect it back up into that pouch. Then food travels down into the small pouch and then goes through a different route to the rest of your bowel. The digestive juices from the stomach and the liver don't meet until further down the intestines. So this gives you the restrictive component like the other two operations, but also a malabsorptive component where you're not actually absorbing all of your nutrients. The average weight loss for this is 65 to 75% of excess weight loss as well, body weight as well, over 1 to 1.5 years. Hospital stay for this is also 2 days in the hospital, 1 night. Occasionally some people need an extra night in the hospital. The complications we worry about with this one are leaks as well, which have been reported anywhere between 1 to 4% in the United States. I do a couple extra little different things on this operation that help keep my leak rate even further down. Once again, I will check after the operation as a leak test with the EGD scope and the air, just as I described in the sleeve. But before doing that, I not only staple everything back together, but then I sew and then over sew all my anastomoses. What that allows is a 2-layer closure. Why do I do that? Because at the University of Florida, we did over 1,000 of these in a row and had 0 leaks. That is much better than a 1 to 4% leak rate nationally. You can get a little swelling after this sewing, and so I see about 1 to 4% of my patients have a little swelling afterwards that make it a little harder for things to go down in the first couple of days. Sometimes we have to keep you in the hospital just a day or two until the swelling has gone down. Mortality rate for this operation is 0.3%, which is low but is not zero, and I'm going to talk about a little bit more in a minute. Complication rate for this over a 5-year period is about 15%. The big complications we worry about long term are first dumping syndrome, which, as I tell a lot of my patients, dumping syndrome is a good and a bad. What dumping syndrome is when you eat something that you shouldn't eat, usually like greasy foods or especially high in sugar, that food gets further down your GI tract than it really should have ever gotten. What that then happens is you feel a little nauseous and you feel not too wonderful, and then you end up going to the bathroom and having a large bowel movement, thus the term dumping syndrome, and feel okay. But basically this food and this sugar is kind of running through your body rather quickly. Internal hernia is also a complication that you can have from this operation because we've rerouted a lot of your intestines. Sometimes they can twist around each other. If this happens, you'll know it because you'll be in some significant pain. You'll report to the ER, they'll do a CT scan, and then they will call me saying, patient, you have an internal hernia, and we'll have to take you to the operating room and fix it. Ulcers have been reported up to 10% of the time in patients with gastric bypass. One of the key ways to reduce this down to 2% or less is to not smoke. So one of my key rules is no smoking. I won't operate on you until you quit smoking and then agree to stop smoking. It's very dangerous, and in any of these operations, the sleeve, the bypass, or the band, we can't afford an ulcer because it would cause major complications for you long term. So in the bypass, additionally, to get this even lower, I will put you on a long-term reflux medicine to help even decrease ulcers even more. So the risk of surgery versus no surgery. Some people are scared of surgery, and surgery does come with some risk. But the big risk is not having surgery in somebody who is morbidly obese. Um, McGill University did a study and what they took a number of patients who underwent surgery versus people who were matched by sex, age, and duration of being obese who didn't undergo surgery. Compared them after 5 years, and what they found was in the no surgery group, 6.17% of those patients had died. In the surgery group, after 5 years, 0.68% of patients had died. So significant benefit long term to having surgery and getting much healthier. So who is at increased risk for surgery? This is for all surgeries, not just bariatric surgery, but if you have 5 medical problems or more, you're an increased risk patient. If your BMI is over 50, you're at increased risk. If you're an older patient, you obviously don't heal as fast as younger patients, so you're a little increased risk. Men just don't do as well with surgery as women do. Women heal better for whatever reason. Diabetics also don't heal as well as other patients, so a little increased risk in surgery. And then people have had previous blood clots. We worry about those patients, but for all my patients, I give you a blood thinner before surgery and after surgery to help prevent blood clots, and we will get you up walking around the day of surgery. This surgery is not that painful, and you can be up walking around and even walking upstairs so it's the day of surgery. Smokers also are very, very increased risk for any surgical procedure, which is why, once again, I ask you to quit smoking before we operate on you. Here is one of the major benefits of surgery and one of the major reasons I do this operation. This is a patient who had a gastric bypass. These are all the medications he was taking the day before surgery. This is his 1-year follow-up and how many of those medications he was taking. You can see he's had significant and impressive improvement. But he is more the norm, and that is what the Journal of American Medical Association has shown in a paper they published in 2004. What they found was in patients who had gastric bypass specifically, but we see this in all our bariatric patients, diabetes was resolved 70 to 80% of the time. Hyperlipidemia or high cholesterol resolved 65 to 75% of the time. High blood pressure resolved 50 to 75% of the time. And sleep apnea is practically cured in every instance. Here's a more recent study that shows a combination of band, sleeve, and bypass, and you can see much similar results, including quality of life. 95% of patients said that their quality of life was improved and better after surgery than it was before. Weight does stay off with proper diet and exercise. We've had data for years that have shown this. So where do we go from here? Well, the next thing you do is you give my office a call. We would be glad to see you and talk more about surgery and what the best surgical option is for you. And we just ask that you fill out a little bit of paperwork when you come in or before you come in. And one of those things is our agreement to comply with therapy. And this is just kind of a contract between you and I. So we both are on the same page and want what is best for you. First is you will take those vitamins that I already talked about and protein drinks before and after surgery. That you will follow the guidelines of the pre- and post-operative diet. That you will exercise on a regular basis. That you will not get pregnant for at least 2 years after surgery. That you will quit smoking 2 months before surgery and remain smoke-free. And that you would follow up with me. I expect to see you at the 2-week after surgery mark, 3-month, 6-month, and 12-month mark. And then I do not like to see my patients gain a lot of weight during the evaluation period. If your insurance requires a large evaluation period, I ask that you would maintain your weight, and it would be best if you lose weight. Any weight you lose before surgery is only going to be multiplied after surgery. Everybody has to get a psychological interview before surgery. This is so we can make sure that you can handle this awesome change that is going to happen to your life and that you are mentally prepared and ready for this change. Everyone will also meet with the nutritionist before surgery who will talk about everything you need to know about your life after surgery and how you should eat and exercise and what you will be eating after surgery. So I'd just like to end with this statement that surgery is a tool. It is a very, very good tool, and it's a very, very effective tool, but you must use it correctly. If you use it correctly, I promise you will get great results and be very happy with it. Thank you, and I look forward to seeing you in the office. Please give us a call, and I would love to answer any questions in the office. Thank you.